This short presentation provides an overview of what community physicians need to know about the clinical education of MCG medical students. Briefly, I will cover three topics. First, where do community physicians fit into the overall training of MCG medical students? Second, what's the big picture? What do medical students really need to be taught during their clinical training? And finally, how well do MCG students trained by community physicians perform when compared with students who are trained in the main campus in Augusta? First of all, let's consider what we're really trying to accomplish during medical school. When you think about it, the transformation is pretty amazing. We start off with first-year medical students, bright, tech-savvy, recent college graduates from the millennial generation, and in 4 years, they are transformed into caring, compassionate, highly skilled physicians. One of these students could be your doctor someday, so the stakes are high. Here's how the transformation occurs at the Medical College of Georgia. MCG is one of the largest medical schools in the country. We now have 2 four-year campuses. 190 students are trained on the main campus in Augusta, and 40 students are trained in Athens. The students spend their first 2 years learning basic sciences and developing their clinical skills. At the end of their second year, the students must pass USMLE Step 1 before they can begin their clerkships. During their third year, the students take 7 core clinical clerkships: family medicine, internal medicine, neurology, OBGYN, pediatrics, psychiatry, and surgery, as well as 1 4-week elective. During their senior year, the students must take at least 7 4-week electives, including emergency medicine. So where does all this training take place? The majority of students are trained at their home campuses in either Augusta or Athens. For many years, Memorial Health University Medical Center in Savannah has served as a clinical teaching site for both MCG students and for those from Mercer University School of Medicine. In 1997, we started our first community teaching site in Albany, Georgia. Based on the success of that site, we started additional sites in Rome, Georgia, Columbus, Covington, Marietta, and Statesboro. Since then, we've continued to add many more community teaching sites with great success across the state. But wait, there's even more. In addition to the Augusta and Athens campuses, MCG has, or will have shortly, 3 regional clinical campuses across the state where students will spend their last 2 years of medical school. 3 years ago, we started the Southwest Georgia Clinical Campus based in Albany. Last year, we added the Southeast Georgia Clinical Campus, which is co-located in Savannah and Brunswick. Next year, we will complete our Northwest Georgia Clinical Campus in Rome. MCG's clinical campuses and community partnerships would not be possible without the help and support of Georgia's area health education centers. As this map shows, the state of Georgia is broken into 7 AHEC regions. The preceptor coordinator in each AHEC serves as a valuable resource, identifying quality medical practices, working with local physicians, and helping students with logistical issues when they arise. So what really needs to be accomplished during the students' clinical years of training anyway? Clinical medicine encompasses a huge body of knowledge. Some students have described the experience of medical school as like trying to drink out of a fire hydrant. By the time they enter the third year, the students have learned a great deal of important information. The problem is they have no clinical context upon which to place it. It's organized in a clinically inefficient way by organ systems or by different kinds of diseases such as cancer, collagen vascular disease, heart disease, infectious diseases, etc. Clinicians take care of patients who present with clinical signs and symptoms such as fever, weight loss, rashes, or abdominal pain. Therefore, what the students need to accomplish during their clinical training is to reorganize all of their file folders into a clinically useful format that they can use for the rest of their lives in the practice of medicine. Every patient care experience gives them the opportunity to reorganize and build upon their clinical knowledge into a structure that they can use to care for patients. I believe that's why William Osler famously said, "Medicine is learned by the bedside and not in the classroom." Patients are the best teachers. So how do students trained in community practices compare with students who are trained at the academic medical center? 10 years ago, when I was the pediatric clerkship director, I compared the performance of students who trained in community practices with those who trained at academic medical centers in MCG and Savannah. Students who were trained at the academic medical center had a traditional clerkship experience, spending about 50% of their clerkship time on the inpatient ward, where they followed 3 to 4 patients daily and made rounds with attending physicians and residents. They spent the other half of the rotation in the ambulatory clinic and the newborn nursery. They also attended approximately 15 one-hour core lectures given by trained faculty throughout the 6-week rotation. Students who did their pediatric training in community practices had a much different experience. They began their typical day by meeting their attending physician in the newborn nursery, where they made rounds on healthy newborns and provided anticipatory guidance to their mothers. They then made rounds on any hospitalized children, although at most community sites there were very few inpatients. The rest of the day was spent in their preceptor's office seeing large numbers of children with common pediatric conditions. They had access to the lectures by videotape if they desired, but they were not required to view them. The students in both groups were comparable based upon their MCAT scores, GPA in the first 2 years of medical school, and their performance on USMLE Step 1. Students assigned to the community sites performed as well as students trained at the academic medical centers on one of their written exams, and actually performed better on the other written clerkship exam. Additionally, students in community practices saw almost 2.5 times as many patients as the students who were assigned to either MCG or Savannah. Clearly, students taught by community physicians have an educational experience that is at least as good, if not better, than those trained at the academic medical centers, at least in pediatrics. Community physicians are uniquely qualified to teach medical students because they provide them with more opportunities to see patients in a real-world environment. And by seeing more patients, the students have more opportunities to reorganize their clinical knowledge, practice their clinical skills, and learn how to think like a doctor. Finally, community physicians serve as excellent role models for the students as they practice the art and science of medicine.